Good morning, everyone. My name is Carl Dietrich. I'm a faculty member at the Swedish First Hill Family Medicine Residency and the Associate Director for Curriculum there. It's my pleasure this morning to introduce our two speakers this morning. First is Dr. Kate Neitzke, a third-year family medicine resident who has her continuity clinic at the King County Downtown Public Health Clinic, and Dr. Jess Sullivan, another third-year resident who sees her continuity patients at Ballard Family Medicine. We're looking forward to hearing them talk today about fibromyalgia. And with that, I will turn it over to our two speakers.
Thanks, Carl. Let me just get our slides pulled up here. All right. Well, welcome everyone, and thanks for the opportunity to talk this morning. Our topic is going to be fibromyalgia and centralized pain. And we are, again, Jessica Sullivan and Kate Neitzke, and from Swedish Family Medicine. We don't have any disclosures to make this morning, so we'll jump right in. So Kate and I, when we were choosing the topic for this talk, thought a lot about the types of patient visits that kind of give us pause as providers. And top of the list was fibromyalgia. I think a lot of us have some inherent dread of these visits, to be perfectly frank, because there's such so many nested layers of dynamics with the patient in these visits. And a lot of us feel maybe less than equipped to really help our patients find solutions for their symptoms. So our hope for today is to kind of review the basics of fibromyalgia, but especially to take the lens of tools and patient-facing language that helps us as providers really build connections to our patients, empower and educate our patients, and change how these visits go. So our objectives are going to be to review a definition for fibromyalgia and the physiology of centralized pain. We hope to help you establish a diagnostic framework, specifically based on the current guidelines. We're going to review some of the evidence-based pharmacologic and multimodal treatments for this disease. And then throughout the presentation, we're going to be talking about strategies to optimize patient engagement in the hope of improving outcomes. So you'll see as we go that some of our slides are colored gray, and those are going to be our more patient-focused slides as we talk. So really kind of getting to the heart of the, I'm going to call it controversy around this diagnosis. We could also use the term stigma, I think. We wanted to do a little bit of background to talk about how we got here. And so the first kind of written down descriptions of this symptom cluster that we now know as fibromyalgia came in the 17th century. Around that time, though, I'm going to do a little philosophy lesson. Rene Descartes was touting his new concept, not really new, of mind-body dualism. And this thought that our minds and bodies are totally separate entities, I think has been one of the big players in why physicians often struggle to accept this diagnosis that is so about the intertwined nature, the mysterious way that mind and body are intertwined. But fasting forward, we'll just go with that, to 1977, we saw the first diagnostic criteria for what was then called the fibrositis syndrome, proposed by Smythe and Moldavsky, and that was going to be a triad of non-refreshing sleep, tender points, and fatigue. As we went along, the American College of Rheumatology in 1990 proposed the tender points diagnostic criteria that some of us learned during med school, and that Kate will talk in a lot more detail about in a bit. And then in 2007, we saw some more kind of legitimacy given to this diagnosis with the first approved drug for fibromyalgia, which was pregabalin or Lyrica. And then more recently in the last decade, both the American College of Rheumatology and many of the leading researchers in the field, including Dr. Clow, whose work we'll discuss a lot in this presentation, have kind of come to understand this more as a spectrum, actually, of a centralized pain physiology that we'll get into as we go. I wanted to highlight this article that was published as recently as 2008 in the New York Times. And it is a commentary on pregabalin, the drug that we just mentioned. But interestingly, it contains a lot of conflict coming from some of the leading researchers in the field. So I want to highlight the kind of the beginning and end of this excerpt. So the beginning is the diagnosis of fibromyalgia itself worsens the condition by encouraging people to think of themselves as sick and catalog their pain. And then skipping down to Dr. Wolf's comments, who's incidentally the leading author of the guidelines from 1990 that proposed the diagnosis of this disease. Some of us in those days thought that we had actually identified a disease, which this clearly is not. To make people ill, to give them an illness was the wrong thing. I think that we just wanted to put this here to highlight the fact that we want to spend a little time up front thinking about the origins and history of this diagnosis so that we can start to interrogate some of the stigma and beliefs that we all probably hold. So to anchor us, here is a case of a typical fibromyalgia patient. FM, sorry, we had to, is a 52-year-old cis female. She's coming in to establish care with you. She has had 4 different providers in the past 4 years. And on your chart review, you notice a history of major depressive disorder, generalized anxiety disorder, endometriosis, prediabetes, hypertension, and osteoarthritis following a right knee replacement. She is on disability secondary to chronic pain. And you also note that prior to that, she had multiple LNI cases open in her chart. And her medication list includes oxycodone, naproxen, and sertraline. So in this kind of case story, there's a couple classic features that we included. The first being just the 4 different providers. I think these patient-provider relationships often end up quite strained, and patients end up feeling neglected or not heard or frustrated with the lack of diagnosis and answers. So we often see that there's a difficulty with continuity of care in these cases. We know that major depressive disorder, as well as multiple other psychiatric diagnoses, are associated with fibromyalgia, and we'll talk a bit about that later. And then another common feature of these histories is some what we would kind of classify as generalized or non-specific pain conditions that can include things like endometriosis. So it's very common to see this in someone's past medical history. And then also fibromyalgia patients can, of course, have secondary or primary even like rheumatologic disease, including osteoarthritis, sometimes even going to the level of invasive interventions, which may or may not be helpful. And we will talk about that. So to review kind of the common symptom profile of a fibromyalgia patient, we're typically going to be seeing a patient who has significant multifocal pain that doesn't have a clear trigger. And often that pain is accompanied by a cluster of other symptoms that include sleep disturbances, specifically difficulty getting adequate rest at night, fatigue, and then brain fog, which can be described differently, but often presents as kind of memory problems or difficulty concentrating. There's also, as I mentioned, often a lifetime history of various pain concerns. These can include things like chronic headache, TMJ pain, interstitial cystitis, endometriosis, even dysmenorrhea, and then irritable bowel syndrome is another common part of this cluster. And then another feature you may hear is just a high sensitivity to any sensory stimulus. So this may present as, being sensitive to bright lights. It may present as patients who have significant side effect burden with different medications. But we'll talk a bit more about why that is part of the pathophys as well. And then just to dial in on the pain itself, as I mentioned, typically the pain is diffuse and multifocal and migratory. These are not patients that can pinpoint with one finger where the pain is located. It often is a pain that waxes and wanes, that has flares and then resolves for a bit. And typically the descriptors that patients use for this pain are gonna be in the more neuropathic bucket of pain descriptors. So thinking about a burning, tingling quality, and then maybe even endorsing dysesthesias or paresthesias along with their pain. And then again, as we mentioned, often you'll see some hyperalgesia features, this discomfort with touch, those kinds of things.
So just talking a little bit about the epidemiology of fibromyalgia, with the acknowledgement that as the diagnostic criteria change, the way that we study the prevalence of this disorder in the population has also changed. So you can think of many of these things as estimates that continue to evolve. In the general population, there's a 2 to 4% prevalence globally. Most of fibromyalgia study has been undertaken in the United States and Western Europe, but there is not really evidence to suggest that that prevalence varies particularly widely across the globe, and it's estimated that there's a 2 to 6% prevalence in the United States, and that the incidence is highest, peaks in the 7th decade of life. It often takes patients many years to reach this diagnosis. And we'll talk a bit about this more later, but there are some sex differences in the way that the diagnosis is applied, typically female greater than male. Notice that I said the difference that the way the diagnosis is applied, not actually difference in people who would qualify for that diagnosis based on their symptoms. And there's limited data, but nothing to suggest significant differences based on race. There does appear to be a significant genetic component to chronic pain states and fibromyalgia that Jess will discuss a little bit later. And then, as Jess mentioned when she was discussing our case, it's important to recognize that people can have a nociceptive pain condition and have centralized pain or fibromyalgia. So 10 to 30% of people with these common nociceptive pain conditions also meet criteria for fibromyalgia at the same time. And important to recognize that in terms of just general disease burden, our fibromyalgia patients are more than twice as likely to have heart disease, hypertension, and diabetes as well. So we spend a fair amount of time discussing the diagnostic criteria because I think that the way that we diagnose this condition and the sort of ability that we have to apply concrete criteria to its diagnosis really helps to legitimize it and empower us to make the diagnosis and kind of move forward in treatment. So the initial diagnostic criteria from the American College of Rheumatology were proposed in 1990, and they include these two components. So a history of widespread pain that had to have been going on for several months, and then pain in the tender point sites. This is something that many of us learned. You can see in the picture on the left, that's an illustration of where the tender points are. There are kind of some obvious drawbacks that you can see immediately now, that it requires a physician exam, and the exam is impractical. It's difficult. It's really difficult to have consistency in how that's being applied in clinical practice. And it excludes a ton of the somatic symptoms that we now know are kind of key components of the diagnosis. And the sort of restrictive definition that was proposed means that if you have clinical improvement and you don't have the tender points anymore, that you no longer meet the criteria for fibromyalgia. So a much needed update came in 2010, also from the American College of Rheumatology, where we start to get a little more systematic about the way, systematic and more thorough about the way that this is diagnosed. So there are two kind of criteria that we continue to employ today. And the first is the widespread pain index. We have sort of a more scientific diagram here, which sort of reflects the way that this diagnosis has changed. And it notes the different sort of body sites where you need to have experienced pain within the past week. And that's per patient report rather than a sort of physician exam. And then the second component is the symptom severity scale. In the initial 2010 criteria, there were up to 41 somatic symptoms reported, including fatigue, sleep disturbances, cognitive symptoms, and kind of numerous others. And the symptom severity scale was something that a physician would discuss with the patient and then assign a score to based on the severity of those symptoms. And then you can see below that there's a combination of a score on the widespread pain index and a score on the symptom severity scale that would indicate that you met criteria. So this was a significant improvement, but still not quite as practical as it needs to be applied in a busy primary care practice. So the 2011 revision gave us this one-page, really patient-centered questionnaire that allowed for a quick assessment in the clinical setting that is patient self-reported, that has very good sensitivity and specificity for the diagnosis. And the main difference here is that we drilled down on several of the most important kind of somatic symptoms to get that second score, rather than the really exhaustive 41 symptom definition. And that allows for the patient themselves to independently fill out this survey, and it gives us a very good sense of whether they meet criteria. So kind of the most recent update in the diagnosis saga is the 2016 revision that has been proposed but is not formally accepted by the American College of Rheumatology. And the one thing that they're trying to update in this case is making sure that the widespread pain index is accurate. And the problem that they're trying to address is that sometimes people will mark enough sites in the widespread pain index to qualify them for a diagnosis of fibromyalgia, when in fact the pain that they're having may be due to a regional pain syndrome rather than the centralized pain of fibromyalgia. So the clarification here is that the pain needs to be present in at least 4 of 5 body regions to exclude patients who just have a more focal regional pain syndrome. They don't change any of the scoring cutoffs or anything like that, but they also focus on the fact that it's really important to know that fibromyalgia can exist as a distinct entity in addition to any other medical condition or pain condition that the patient has. They wanted to make that extra clear that just because someone has a different painful condition, that does not mean that they don't also qualify for a fibromyalgia diagnosis. And so as we've evolved from the tender points exam to this more kind of global definition, and we've gotten more patient-centered in the way that we're able to apply criteria, there's a bit of a paradigm shift in how we think about fibromyalgia, and we can think about it more on a spectrum, which really goes along with the pathophysiology that Jess is going to describe in a minute. You can use the diagnostic criteria that we have, these pain index and symptom severity scores, to assign a patient a location on this sort of fibromyalgia-ness or severity scale. And this doesn't necessarily mean that that it specifically correlates to the treatment path that you would do, but it is a good way for us to kind of conceptualize that people, on the lower end of the scale may not technically meet the fibromyalgia diagnosis, but we can still consider them as somebody who has a centralized pain component to their presentation and can help us to understand how we might best care for them. And so I wanted to come back, since I mentioned that the epidemiology of this condition has been really affected by the way it's diagnosed. And just note that one of the biggest misconceptions I think that we have is that this is a diagnosis for female identifying patients, and that's not true. And so the 1990 criteria, as you noticed, when they're describing the tender points, they have 3 female bodies where they're demonstrating the tender points on them. And we found in subsequent studies and revisions of the criteria that women are much more sensitive to that exam, particularly. So you're just losing quite a few patients who would otherwise meet criteria. And so as you can see, the ratio of female to male decreases as you go through the revisions. And it is actually much closer to 50-50 than we previously realized. So as you're thinking in your clinical practice, when a person comes to you, trying to sort of address that inherent bias that I think many of us learned when we were learning about this diagnosis, and realizing that this is a condition that anybody can have. And just to address the diagnostic criteria, you'll note don't have any lab or imaging criteria in them, and that really hasn't been necessary for effectively being able to diagnose this condition. And you'll note that many patients in their journey towards getting this diagnosis have had a ton of testing done and a ton of interaction with the healthcare system. And so when they meet you, really what you should think is, do I have a significant concern based on their physical exam or their history for primary rheumatologic or other nociceptive pain condition? If the answer is no, then labs and imaging are not generally indicated. If there's something objectively that you found that causes concern, you can do sort of a very basic rheumatologic workup. You could consider a one-time rheumatologic consultation. And other than that, there's not additional workup that is consistently recommended. So now kind of circling back to where we started, we were discussing what the diagnosis of fibromyalgia means. And there's, I think, two components to that. What does it mean to the patient and sort of where they go from there in their treatment? And what does it mean to the healthcare system? And I think that there's been a lot of cynicism and a lot of negativity around what this diagnosis could mean. And in the worst case scenario, there's an assumption that when patients are assigned this sick role, they will seek out much more healthcare, many more healthcare resources, and that'll have a cost impact and kind of a burden on the healthcare system impact. There were two studies done based on the London fibromyalgia study that looked at this very question. And they evaluated patients following a fibromyalgia diagnosis and found that, in fact, they have a decrease in costs, mainly reducing those tests and diagnostic procedures that we just mentioned aren't really necessary. And also from a personal level, noting increased health satisfaction, fewer symptoms, and just sort of actually a general more effective use of the healthcare system. And then from a personal level, these are images from a New York Times Patient Voices article on fibromyalgia. And this notion that's repeated again and again is not, oh gosh, I thought I was totally fine and now I have this diagnosis of fibromyalgia, so I feel sick all the time. Patients were feeling sick before, but they thought it was something much more dangerous, immediately life-threatening. They were going through a lot of stressful tests and procedures, and actually receiving a diagnosis that they can do something about and putting an end to kind of that rabbit hole of diagnostic procedures is actually a relief to many patients. That obviously doesn't mean that every single patient feels great about receiving the diagnosis, but it is just to challenge some of those preconceived notions.
Yeah, so I think a large part of helping our patients come to that point of feeling relief and understanding their diagnosis is effective patient education. And a lot of our data around this disease has shown us again and again that education is a key component to treatment of this disease and to getting good response. So I wanted to take a bit of time to do what may seem basic, but to review pain physiology, and specifically to review it from a lens of how can we help educate our patients on what's going on in their body so that they can engage better with treatment. So the left-hand side here is just to briefly review kind of our two, I guess, primary peripheral pain mechanisms. So the first would be our nociceptive pain receptors, which are delightfully illustrated from this book, Explain Pain, that I'll reference later in the middle. So we have three different, to simplify, receptors at the ends of our sensory neurons. We have mechanical, temperature, and chemical receptors. And if these receive adequate stimuli, they generate an action potential, which then sends a signal to the central nervous system. We also have a pain generating mechanism that we have termed neuropathic pain, and that typically is going to come from compression or damage to the nerves, which similarly cause signals to be sent to the CNS. On this right side is kind of a framework for talking with our patients about these two basic peripheral pain mechanisms. And again, the end goal with this education that we'll walk through is to help our patients understand maybe why the more conventional pain treatments like NSAIDs and opioids, for example, are not going to be as effective in centralized pain. But anyway, so the principles on this right side are adapted from this book, Explain Pain, by Lorimer and Mosley. They're two Australian neuroscientists and therapists, rehab therapists. And they've laid out a nice framework. So if you ever want to reference their book, I would recommend it. But one of the core concepts to convey to our patients is, first of all, that pain is not necessarily something to be inherently feared. It is a protective device for us as humans. It signals us to threats, and in a lot of ways, it can be a useful ally when it's not misfiring or amplified, as we'll talk about. And again, the way that our body typically initially processes pain is that we get signals from our peripheral sensors, and those trigger our nerves to fire. However, the key component here is that our brain is ultimately the decider of what, signals those, how those signals are processed. And so we have a really strong set of evidence from our experience as human beings that our response to pain deeply depends on context. So one example that you could think of is if you're running away from something and you step on, say, a shard of broken glass, you might not notice that pain until much later because your body in that moment has decided that that pain signal is not important or not the biggest threat that you're facing. So then if we shift over to thinking about what happens in centralized pain, these more straightforward mechanisms get a little more complex. So fundamentally, the thought about centralized pain is that this is a maladaptive amplification of those peripheral pain signals that happens at the level of the CNS, typically in the brain, but may also, the spinal cord may also be implicated. And we as humans have very intricate interplay between our ascending nociceptive pathways that we just discussed and these descending analgesic pathways that are mediated by a lot of the neurotransmitters that you see at right. And I want to highlight a couple because they are thought to be the most implicated in the pathophysiology of centralized pain. So one of the main players here is the norepinephrine serotonin pathway. It's thought in the current research that that is the pathway, the descending pathway that is most attenuated in fibromyalgia. We also have endogenous opioids that play a role in our kind of autoanalgesia or modifying those pain signals, but those are thought to actually be upregulated in fibromyalgia. So we have plenty of endogenous opioids, and that is partially why giving external pharmacologic opioids in this condition really doesn't make much of a difference. But when we look at the norepinephrine serotonin pathway, that's going to be a target of a lot of our pharmacology that Kate will talk about later. A couple other interesting facts to mention is that GABA is also implicated in this descending analgesic pathway. And there is an interesting study that looking at a retrospective at a pain clinic registry showing that moderate alcohol consumption actually improves pain severity and mood scores in fibromyalgia. Likely mediated by this pathway. And then Kate will discuss later that cannabinoids are another interesting frontier, but not one, unfortunately, that's been well explored yet. The other question that comes up with centralized pain that Kate alluded to is, why does this happen in certain individuals and not others? And so there's always the nature-nurture debate, but a couple things that we know. So familial transmission is really robustly demonstrated. The study that Kate had alluded to looking at familial patterns in fibromyalgia showed that if you have a first-degree relative with chronic pain or fibromyalgia, your odds ratio of having that disease is 8.5. We think that pain sensitivity is likely a polygenic trait, but likely mediated by various variations in how we process our neurotransmitters and how efficacious those things are. So that's a proposed mechanism of genetic transmissibility. There's also been some interesting twin studies done that essentially reveal that chronic pain states are about 50% genetic and about 50% environmental. And then again, there's this question of the layering of different pain types, right? So someone who has a primary nociceptive condition that then goes on to exhibit fibromyalgia or centralized pain symptoms. It's not quite known why or how those particular patients progress to a centralized pain state, but likely having that constant nociceptive stimulus may play in. So again, taking it back to how we talk with our patients about this, I think that one of the core goals of our education is to help our patients understand that the pain that they are feeling in their body does not necessarily mean that there is something wrong in their tissues. And we have to be thoughtful about how we present this, again, so that we're not minimizing our patient's symptoms. But it is an empowering concept to help people understand that the pain they're experiencing does not necessarily mean that something is fundamentally damaged in their bodies. And so we think about centralized pain, the analogy that's used a lot by our good friend, Dr. Clow, who is one of the leading researchers in this field, is that centralized pain is kind of like a guitar amplifier. So if you think about the various nerve signals that our brain is receiving as plucking guitar strings, every single one of them will have its volume turned up if you turn up the amp. And so that's kind of similar to what the brain is doing, right? If we have that imbalance between the brain being able to say, actually, this pain signal, not important to me, and then the pain signal is constantly firing, you're going to get a picture of widespread kind of episodic pain like we were describing. Another important concept to share with our patients is that basically our thoughts and beliefs are nerve impulses, just as our pain is. And again, this does not mean that pain is all in our head, but in some ways it is. And we know from functional MRI studies that a lot of our pain processing regions are really closely linked to the areas of the brain that process emotion, memory, and movement. And so this has two kind of offshoots for our fibromyalgia patients. The first is that this is kind of thought to be why we see so many concurrent fatigue and memory and mood symptoms in this disorder. You know, these regions overlap, and it's hard to know the chicken and the egg at this point in our research, but knowing that they are closely linked can help patients think about their disease process as a holistic thing. Another thing that's been proposed is just the idea that you know, we do see a lot of concurrent history of trauma in these patients, and I'll talk about this a bit on the next slide, but it's thought that if a pain signal is experienced in an environment where the patient is in more of a fight or flight state, then that pain signal is more likely to be perceived as dangerous, and therefore more likely to be kind of hypersensitized within the brain's processing. So all things that we can share with our patients in the hopes of helping them come to terms with what's happening in their body without too much unnecessary fear. And then, as I mentioned, we see a lot of overlap between psychiatric conditions and then these regional pain syndromes that we alluded to, and then fibromyalgia. And the thought is that there's likely a lot of common triggers and overlapping pathology in all of these conditions. One proposed mechanism is just some neuroendocrine or stress response abnormalities, but this is a field that remains, I think, ripe for further research as we help to clarify this for people. So then, kind of pivoting to the piece that we're all oriented toward as primary care providers, how do we treat our patients? How do we partner with them and help them come to terms with this diagnosis? Fundamentally, as you can see from this figure, this is a very multifactorial disease, and therefore treatment needs to be multimodal. And central to the treatment process is not us as providers, it's the patient themselves. So that self-efficacy piece is going to be a huge theme of our discussion here. Another piece to remember, though, is that we're not the only point in healthcare that can be an ally to our patients throughout this process. So remembering that we can include many different treatment team members, including our behavioral health colleagues and our physical therapy colleagues and family support, all these pieces. So we will walk through each of these bubbles with, again, an emphasis on actually the non-pharmacologic therapies, because those are so critical in this condition. So first and most important is our friend exercise. And this is very intentionally placed at the start of our treatment list because it is so critical to the primary goal of treatment, which again is not always to resolve pain. In fact, most of the time it's not. Our goal here is to get our patients back to a level of function and a level of quality of life that is acceptable to them. So the take-home central message with exercise and fibromyalgia is that it's got to be gradual and it's got to be really gentle, and essentially. So the mantra is start low, go slow. And we have a lot of data to show that there's not a clear superiority of one exercise type over the other, but in the realm of studies that we've looked at, aerobic exercise is the best studied and has the best evidence. The Cochrane review on this topic kind of looked at multiple different studies, and this shows aerobic exercise, again, varied amounts and types, so we'll talk about that a bit, but in general, it shows moderate quality of life improvement and then a mild pain improvement. And because this is the best studied, it ends up being the comparison group for a lot of our other studies of exercise types. So things like stretching and resistance training have also been looked at in fibromyalgia. And while we assume that they are mildly helpful, they are not quite as robustly shown to improve quality of life as aerobic exercise. However, there's a recent study, a randomized controlled trial of 226 people published in the BMJ that showed that Tai Chi was actually comparable, if not superior to aerobic activity in its outcomes. So another exercise modality for us to explore with our patients. And again, just kind of coming back to this question that I think is in our minds as PCPs, we do a lot of exercise counseling with our in our wellness visits, thinking about exercise targets, that kind of thing. Really, the message here is just any increase in activity is going to be beneficial. But for some context, the studies that I read were primarily looking at quantities of building up to exercise that's about 20 to 30 minutes, 2 to 3 times weekly of low to moderate intensity exercise. So still kind of below the exercise guidelines we might share with our other patients. From the patient perspective, the message here is that we as physicians are not only physicians, we are also salespeople, and we have to help our patients understand how critical this piece of their therapy is. So the thought process or the concept you can convey to your patients is that the reason we move in fibromyalgia is to help recalibrate those pain signals that are coming to our brain and help our brain understand that movement is not necessarily a threat. So we're trying to send more useful information to the brain. Another way to frame it is that exercise is, in the studies, more efficacious than most of our drugs, but it also works as a drug. This is a way for us to build up naturally all of those good neurotransmitters that help attenuate our pain signals. And then another key concept from a lot of the researchers in the field is starting by framing this goal for our patients, not so much as starting to exercise, but just as incorporating more activity or movement. Again, we want to be really cautious not to push our patients too hard so that they overexert themselves and end up in more pain. And so framing it initially as just moving a little bit more throughout the day and then building up to a point where you can feel like you're exercising is a good way to go. We also have a lot of data to suggest that the fear of movement that is so common among many of these patients is really strongly related to decreased quality of life and to symptom severity. So that's something that we can target both here with our exercise and then also with CBT, as I'll talk about in a bit. I just wanted to highlight a couple things from this infographic on the right that, first of all, our physical therapy colleagues can be really wonderful allies here in helping develop thoughtful movement programs for our patients, especially those who might be really apprehensive about starting. And then another good tip to share with our patients is that it's okay to start moving the least painful parts of the body first. You don't have to go straight for the pain centers. It's all right to avoid those for a bit and seek movement elsewhere. So another really critical piece of our therapy here is going to be, again, that self-efficacy and then the mental battle that is dealing with a chronic pain condition. So we have great data to show us that education actually improves symptoms and outcomes in this condition. And so not only can you walk your patients through pain physiology to help them have that knowledge, but there's also some excellent resources to point them toward, especially for our patients who are little bit more interested in digging deep. So Dr. Clow has a YouTube video that is his kind of group class for his fibromyalgia clinic that is about an hour and 15 minutes, and it's a nice walkthrough of the physiology. And then the University of Michigan has some lovely modules that are basically like an Adobe Flash program that patients can walk through for free to look at some of the therapeutic interventions and the disease process. We also don't want to forget about the sleep disturbances in this condition. So making sure that we're doing a good job of giving our patients tools for sleep hygiene and good rest is important. And then finally, CBT is another really critical component here, addressing, as we said, that fear of movement, but also really targeting a few other cognitive pieces that are linked to poor outcomes in this this disease process. So first of all, that catastrophizing phenomenon that can be common in some of these patients that we get to work with. Thinking about recalibrating, again, those expectations that pain will get worse and that it is damaging the body, and trying to reframe that. And then also really focusing on making sure that our patients have realistic expectations for their treatment. So focusing on function rather than on getting rid of symptoms. And then another really exciting group of therapies that is unfortunately fairly kind of under-researched in the allopathic medicine sense is our complementary and alternative therapies. There is a nice meta-analysis in the Journal of Pain Research from 2013 that walks through several different CAM approaches specifically to movement and shows us that essentially we see moderate improvements in pain and function from many of these interventions, but the studies are fairly limited in terms of that they're only primarily open label studies, and they're often only studied in the US and Europe rather than in places where these therapies have originated and may be more efficacious. However, the upshot of a lot of this meta-analysis was that there's almost no adverse effects reported from these modalities. And so you have the potential for high benefit and relatively low risk. So it's absolutely something that we can consider including in our therapeutic plans. Other modalities that are commonly used here are acupuncture and biofeedback. You'll note that you don't see massage, and that's primarily because of the kind of hyperalgesia component of this pathophys, that massage is often not as helpful, though if a patient is interested in trying it, this is a place where we can let our patients be our guide and help empower them to choose the modality that they think will be a best fit for them.
So I just want to kind of conclude our treatment part of the talk by discussing medication. And as just mentioned, there's a reason that it's last. We as providers and patients are often conditioned to think of medications as the first thing to do for almost anything that ails us. And so that's kind of a hard barrier to overcome, especially when patients are coming to us with a long history of receiving various medications and having that be the mainstay of their treatment. So you could think of these medications, they are effective and they have a lot of data behind them that they do reduce symptoms somewhat. And you could think of them as a tool to sort of continue your conversation and build your therapeutic alliance with the patient by sort of offering some of these therapies while continuing to really emphasize the sort of multimodal treatments that Jess was bringing up. And I think that another kind of important thing that Dr. Clow had mentioned in an editorial discussing the fibromyalgia pain medications is that we often have a barrier, a mental barrier, where we feel like if this pain were quote unquote real, and what we mean by that is we tend to mean nociceptive pain that we understand from a more concrete standpoint, that we would be better able to treat it, when in fact all pain medications for all types of conditions, nociceptive and centralized, tend to really only have a modest effect. And there's no difference in the amount of pain reduction between these medications for centralized pain and the other classes of medications we use for nociceptive pain. they are, as Dr. Klaus says, as good as it gets. They're as good as any other pain management, pain medication for any other painful condition. So all of these medications are first line recommended. This is based on the 2012 Canadian fibromyalgia guidelines, and those are based on level 1A evidence, which is numerous randomized controlled trials that all support the same conclusion of effectiveness for these medications. There's 3 main classes. There's the tricyclic compounds. Most well studied are amitriptyline and cyclobenzaprine, which is one that we don't often think of when we're thinking about tricyclic medications, but this is in fact, in Dr. Klau's expert opinion, his first choice for fibromyalgia patients. He uses a low dose of that a couple hours before bedtime for patients, and finds that that has a significant improvement in their ability to get a restful night's sleep. And there's a 2004 meta-analysis that supports that conclusion as well. The next category is SNRIs. Many of us are familiar with duloxetine and use it for various conditions, neuropathic pain and centralized. And the duloxetine and milnacipran are the most well-studied SNRIs. We're typically more familiar with duloxetine. It has been shown in systematic reviews to reduce pain, sleep disturbances, reduces depressed mood, and really is a great kind of backbone of fibromyalgia treatment, and the dosing can vary as noted there. And then the third class is gabapentinoids. Gabapentin and pregabalin both can be used. The kind of pearl for using these medications is to dose them with 2/3 of the daily dose at bedtime, because you're really trying to optimize the sleep benefit that you're getting from these medications. And in the systematic review that compared duloxetine, pregabalin, and milnacipran, the 3 FDA-approved medications, they found that pregabalin is superior to duloxetine in reducing fatigue. So each of them has their strengths. Each of them can be used to address different symptoms. And when you're thinking about where to start, thinking about the balance of patients' pain, sleep disturbances, depressed mood, and mental fog can help you decide which one to start with. But you'll also note that patients are on a couple different classes within these first-line medications, and that's totally fine. Kind of second-line things to just briefly mention. SSRIs do seem to have some effectiveness, and there's just a caveat on that, is that the older, less specific SSRIs at high doses have more noradrenergic activity, so they behave more like SNRIs. So you can find that with fluoxetine, sertraline, and paroxetine, that those at high doses can have some of that noradrenergic activity. You need to control that benefit along with the risk of having them at the higher doses. And the newer, more specific SSRIs really don't have that quality to them. So they're less effective for pain. And then, as we mentioned, there's a very small Cochrane review of nabilone, a synthetic cannabinoid that's not really routinely prescribed in our practice, that didn't really show a whole lot in terms of pain relief. But we do know, not from as many formalized studies, but that cannabinoids have a ton of potential for relief of chronic pain with not a significant burden of side effects if CBD rather than THC products are used. It's just difficult to come up with a formal recommendation given dosing inconsistencies and things like that. So just to finish off treatment by talking about what doesn't work. So the classes of medications that are typically used for nociceptive pain don't really work in centralized pain. And so opiates, I think that the overarching thing I want to discuss is there's a 2016 article in the Journal of Pain Medicine where they looked at the effects of chronic opioid therapy on patients with fibromyalgia versus not having a diagnosis of fibromyalgia, they found that essentially that neither group of patients did well on chronic opioid therapy at baseline 4 months and 12 months. And pain and activity outcomes were poor at 12 months, regardless of whether you were using minimal opioid therapy or you were using kind of a more full-blown chronic opioid therapy. So just like with our other chronic pain patients, we know that it doesn't tend to help, and it can actually make our patients who already have hyperalgesia worse. And then for NSAIDs, there's a 2017 Cochrane review regarding this, and they don't see significant benefits, which makes sense to us because NSAIDs are focused clearly on nociceptive pain. They are not addressing the neurotransmitter pathophysiology, and so that kind of makes sense to us as well. And then as far as patient communication, setting unrealistic expectations with the patient that their pain will go away is not going to be helpful. Jess mentioned the maladaptive behaviors, catastrophizing, and going along with that sort of a lack of sort of self-efficacy or engagement in the multimodal aspects of treatment. And so we have a really good chance there to form an alliance with our patients and help them to become more active participants in their treatment, and then continuing to pursue invasive surgical procedures in an attempt to modify pain when your suspicion is that this is a centralized process is likely to make things worse, especially from a functional perspective. So just to conclude, we're kind of at the end of our time here. Bringing it back to the beginning, we come into visits regarding chronic pain with a lot of emotions and insecurities, and those visits at their worst can be kind of adversarial, and we can feel a little bit like we haven't provided the type of care we want to provide. But at their best, they can be a time to really provide valuable patient education, really form an alliance with the patient, and allow them to feel empowered, that they understand what's going on with their body and they understand what they can do to fix it, and they can see their physician as a part of their support team rather than someone withholding treatment or someone who doesn't know what's going on with them. We wanted to make sure everybody's kind of up to date on the best way to diagnose fibromyalgia in an efficient and clear way so you can feel confident in that diagnosis. Give you strategies to discuss pain physiology in a way that doesn't suggest that it's all in their head or not real, but rather give them a way to understand their best treatment, and really focus on the multimodal treatment strategies, using medications as helpful adjuncts, but not as the core of therapy. And with that, we'll just put our references here and take any questions if there are any.
Hi there, I raised my hand. I think maybe it's my question. Great job, you guys. Thank you so much for that. It was so helpful. I was wondering, did you read anything about like the relationship between fibromyalgia and irritable bowel disease? Because I feel like just looking through my patients, I have a couple where it seems like they might have both. Or do you think the symptoms of fibromyalgia can kind of encompass the symptoms people might have for irritable bowel?
Yeah, absolutely. I think that they're just correlation-wise is a very, very strong link between irritable bowel and fibromyalgia. That's thought to be potentially mediated by some of the same like hyperactivated neuroendocrine pathways, but it's still poorly understood. But all that to say, we did see a ton of discussion about the links there and the commonality of seeing that in similar patients.
And the experts in the field are kind of moving towards not even really needing a diagnosis specifically of fibromyalgia, but like being a person who has centralized pain, and that can be someone who had TMJ, they had painful periods, they have IBS, and they're somebody who just has that predisposition towards all of those conditions.
Thank you.
Okay, we're gonna look at the chat really quickly. So the question about how do you spell Dr. Clow, C-L-A-U-W, and the reference that I think maybe you're referring to is the YouTube video, and so that title is called Chronic Pain, Is It All in Their Head? And that's pretty easily accessible. And then the other reference that we'd just like to highlight again is the Dr. Clow JAMA article that has the great summary table for the Canadian fibromyalgia guidelines. I think as a point of care reference for us as PCPs, that's a really useful tool.
And we, if anybody wants our slides with our notes in them, we put a lot of links in our presentation notes. So that can be a way to get those resources.
And then there's another question here about efficacy for TENS units, OMT, or acupuncture. There were not great studies that I came across. That said, I think that in the OMT world, I would imagine there's a ton of great resources to be accessed for patients here. TENS units were briefly discussed as kind of a toss-up, again, because they typically target more neuropathic pain, and this is not entirely the mechanism of fibromyalgia pain itself. And then acupuncture was actually a modality I looked for data on and didn't find a lot, but the common thinking is that it can be useful in the same way that a lot of our other CAM therapies are, so worth exploring. Well, thanks everyone. We appreciate your attention and happy to answer any other questions if there are. Otherwise, I think we'll head out.
Thanks for watching. Hit the subscribe button for more medical content.